Well, will you behave yourself?
No, I promise.
Oh, there. Where is it? Let's go over there. Janet's coming. Oh, good. So we'll put Janet up here with us.
Lancaster? Uh-huh. We're good now.
Good afternoon. We're all glad you're here. The first thing I want to ask is that if there are people that need sign language and interpreter, it's probably best to come down to one of these rows in front, this is where these folks will be. And the other thing I'll mention is that if someone will need assistance with a microphone or getting to the microphone, please, if when your number's called, if you sort of wave or just let us know ahead of time so we can make sure we accommodate that as part of it. Again, what incredibly amazing compliant folks that we just say one word and everybody gets quiet. It's remarkable. So, my name is Dave Richard. I'm the Deputy Secretary for Medical Assistance at the Department of Health and Human Services. And first of all, welcome. And we're really thankful that such a great crowd shows up on a Friday afternoon. Although I think the rain out there helps get people here, so you don't have a lot of other things to do at this point outside. So we're thankful for that part of it. And we really appreciate the willingness for people to take time to help us think more about how we do Medicaid transformation in North Carolina. As you know, we've embarked on this journey for the past year, and now we're working toward increasing our efforts with CMS and making sure our transformation gets on a much quicker pace. But what we want to do is make sure that we have a chance to listen to people across the state and have information coming to us from people across the state as we get to this next phase of our work around transformation. So what you're here to do today is very important to all of us. And first start out by saying is that we call it a listen session because that's what it is. We want to listen to you, so we're not going to have a back and forth conversation about the waiver, but hear what you have to say. That's the most important thing for us to do at the department. There are several people from the department here. I'd like for those folks to raise their hand here, because you'll note that we'll all be listening, and there are folks in the back of the room with the department also, but again, that there are a lot of folks here that will be taking your comments and hearing what you have to say. And also note that you have an opportunity to continue comments by written comments, and up here is the how you can do that. So please, if you have much more extensive comments than you're able to do today, please feel free to write or email or do the other ways that you can communicate. To try to accommodate everybody, we're going to do 2 minutes is the length of time that people have to speak. When you're right here, there's a lady right in front of you that will have a yellow and red sticker that they will raise, or sheet that will raise. And that yellow one means you've got 1 minute left. The red one means you have 2 minutes left. Excuse me, you have no time left. It wouldn't work with it, 2 minutes left. You have no time left. And if you keep going, then I'm going to stand up and act like I'm going to be imposing to stop you. So what we really hope you do is appreciate that time. People have been terrific in the other listening sessions about doing that, because we want to hear from everybody that signed up. We'll do a little bit of pre-work in a couple of slides, and so I want to make sure that we have a chance to do that without any further conversation from me. So it's my pleasure to be able to introduce to you a newer member of our team at DHHS, Kristen Young, who is right here in front. She'll come up and speak. Kristen is our Deputy for Policy and Operations, Deputy Secretary for Policy and Operations inside the department. And I just say a few words. She wouldn't let me do a full resume on it, but when you Google her and find a full resume, you'll be incredibly impressed about someone who has the talent and skills that she has that have come to North Carolina to work with us. What I can say is that her previous job, not only did she have inside CMS at a high-level position in CMS, running a lot of work around what happens with the Affordable Care Act, but she also had the opportunity to work in the White House. So it's a pretty impressive thing. It impressed me when I heard it, so I want to let you know that. But more importantly, what I'll tell you is that Kristen is someone that is very close to Secretary Cohen, has her ear every day, and she is who she counts on to make sure that the department is running in a proper way and developing a proper policy. She's incredibly smart, and we are outrageously fortunate to have her in North Carolina along with Secretary Cohen. So, further ado, Kristen Young.
Thank you, Dave, and hi everybody. Secretary Cohen is sorry that she couldn't be here today, but Dave and I are here, our team is here, and we look forward to talking with her about what we learned today. So as Dave mentioned, the primary purpose of our time with you all today is to listen and hear from you about what's important to you and your interactions with the Medicaid program. But I want to start by saying just a few words about why we are here and what we're trying to accomplish. All right, we'll go without slides. So as all of you know, the Medicaid program in North Carolina provides services to 2 million people. About 20% of the state receive care through the Medicaid program. And as we think about the people we cover and the services we provide, we know that about half of births in North Carolina are covered by the Medicaid program. We provide irreplaceable safety net services to those who have long-term care needs, and we provide a life-saving safety net to people with disabilities living in our communities. So that's our people. As we think about our dollars, we know that about 45% of Medicaid spending is for those with disabilities, about 30% is for children across the state, and about 15% is services for seniors here in North Carolina. And the Medicaid program today provides essential services and delivers excellent care to folks across the state. But we also know that there are areas for improvement. There are things that we can do better. First and foremost, here in North Carolina, we have an uninsured rate that's still at 11%. It's higher than the national average, and it's much higher than many of our peer states, which have been able to drive their uninsured rate well into the single digits. So there's more that we can do as a state to make sure that families have the security and peace of mind that comes with affordable access to healthcare coverage. Second, we have an opioid crisis that is ravaging communities across the state. As all of you know, it's hard to find someone in North Carolina, or indeed across the country, whose life hasn't been touched by the opioid crisis in some way, whether it is a loved one or a colleague, someone at church. Opioid and opioid abuse is ravaging communities and tearing families apart, and we as a state need to do more to make sure that we are tackling this epidemic and providing needed services to those who need them. Here we go. And finally, we also have steps that we need to take to align our payment incentives and drive value in the Medicaid system. We have a lot of dollars that we spend on providing care for services, and there are more steps that we can take to make sure that as we spend those dollars, we are buying health and not just buying health care. And so that's what brings us here today to listen to all of you. The Medicaid program needs to innovate and evolve. There are major changes coming up as we transition the Medicaid program from fee-for-service to managed care, and our team has been preparing and working on those changes for a number of years. A lot of that work has already involved listening to folks across the state, and the time we're spending with you here today is a continuation of that effort and an opportunity to hear more from you as we develop further in our thinking about what managed care will look like here in North Carolina. And so to shape that conversation, we have asked 7 specific groups of questions about the Medicaid program and the transformation that is coming here in the state. First, we want to hear from you about integrating behavioral and physical health care, how we can make sure that we are caring for the whole person, especially for those with significant behavioral health care needs. We want to think about how we support provider transition as the Medicaid system evolves and what we can do to make sure that we are helping healthcare providers through the change from fee-for-service into managed care. We want to think about steps that we can take to invest in care management and population health. And we also want to do more to think about the social determinants of health, what we can do to make sure that Medicaid is fully invested in the elements of health and well-being that happen outside of a healthcare provider's office. We're interested in having a conversation about how we improve the quality of care and how we pay for value across the healthcare system. And finally, we want to hear from all of you about how we increase access to coverage and improve treatment for those with substance use disorder. So with that, I think I will move us on to the main event and hear from all of you. And so the way this is going to work, as Dave alluded to, everybody who's signed up to speak has a number on their name tag, and we'll ask speakers to just sort of line up in order, starting with the first 2 or 3 speakers, and then people can fill in after that. We won't go through and call numbers, so just keep your eye on the number that's up here in front, and keep the line moving. And as Dave mentioned, we have a timekeeper here in the front. She'll hold the yellow card when you have 1 minute left and the red card when you are out of time. And then Dave will bring his imposing presence towards you if you go over time. So we have a lot of folks scheduled to speak today, and I think if speaker number 1 could make his or her way to the podium, that would be fantastic. Great, come on up.
If speakers 2 and 3 want to go ahead and line up, then we'll be able to move a little quickly through everything. And you're welcome to have a seat here or just stand in line while we speak. Thank you.
I'm Jerry Rice. I'm an advocate in the community. Most people know me, and that's out of question. What I would like to know, if opioid is such a big issue and it's across the state as a big emergency thing, if the mental health reform in 2001 was supposed to be the true mental health reform and we were really doing all the great work, why have we got the epidemic today of opioid? That'd be a big question. The other thing is, if we got such an epidemic in some ways, but a lot of good in other ways, why do we have the emergency room at Mission Hospital for the last 3 years packed out the door and those sites in the foreseeable future ever making anything any better? All we live on is promises. That's all we get is promises. Behavioral health. The hospital has never cared about behavioral health in the past, but they do today. Why? Because of the funding stream. It's all about money. It's not going to the services of the people. Don't ever believe that you're getting excellent services as what you've heard. You're getting bare bones or nothing, and you're really getting in between that. I take a hard line approach because I've heard politicians before. I've heard the guard change over the years. They only give you 2 minutes to speak. What can you say? I can say a whole lot. I can strike a match in a minute. Now, the big issue here, why don't we just turn it over to value option? We at least get something. We don't get blockade at the front door of the MCO. First of all, we need to have a grievance way of getting appeals heard, and we don't have an ombudsman. We don't have anybody to go to except the MCO, and they use the strong-arm tactics that, you know, if you ain't going to listen to what I'm going to give you and you're going to take it, we're going to turn you into DSS. We're going to strong-arm you, and you ain't got no protections. unless you've got a lawyer. Well, how many people on Medicaid can afford a lawyer? Where in the name of God can you get anybody in the state of North Carolina to take your case? Disability rights is supposed to be. I'm telling you, we do not have anybody to represent us in the state of North Carolina, period. If you can't access them, what good are they? Uh-oh, they're calling me a safety net. My God, they call this a safety net? I'd hate to see something that's going to eat me alive. Thank you. I got the fire burning now, you can help me.
Hi, my name is Judy, and this is my guide dog, Prince from Guiding Eyes for the Blind, and I am here to talk about the need to expand Medicaid. I am in a situation where I lost my job after being employed for 14 years, which translates to losing my insurance. I love my job. My employer decided to change the way they provided care for the people I was assisting, so I lost my job, and I lost my insurance. I do not qualify for affordable insurance because I'm in the middle of a divorce situation and also because I have no income. I have applied for Social Security disability, but I have not received information about that eligibility yet. And so in the meantime, I have no insurance. And if I do get qualified for Social Security disability, there's a 24-month waiting period. So in the meantime, I have lost my protective shield. When I go up and down my basement steps, I worry about falling. When I'm out for walks in my neighborhood with Prince or my cane, I worry about injuries. You know, I was walking earlier this week with my cane, and I don't know if somebody had left a door open to air out their vehicle, but it was across the sidewalk, and I ran into it because my cane doesn't protect me from the waist up. Luckily, there was no injury, but there could have been, and I have no way to cover that. Also, there is a history of adult onset diabetes in my family, and now I have no idea when, if that can happen to me, because I don't have those preventative doctor's appointments anymore. So I am here to encourage ways to be found to increase insurance through Medicaid for people in situations like me. Thank you.
My name is Leslie Boyd. Some of you know me as a healthcare advocate. My son died 9 years ago because he was denied access to health care. A birth defect was a pre-existing condition, and with that he couldn't get insurance, and without insurance he was denied the care he needed, and he died. I consider it murder. When we have still up to 5 people dying in North Carolina every day, and we're talking about privatizing Medicaid instead of expanding it, when you privatize something that has a limited amount of money, you have to take a piece out of that pie to line somebody's pocket, and that money then will not go to care for somebody in need who could well die. We did this to mental health services a dozen years ago in North Carolina. That system imploded. I went back to work 2 weeks after my son died. I had an email that said 3 young men in North Carolina had died after being released from psychiatric hospitals with no follow-up plan. 3 dead bodies, plus my son, 4 dead bodies. There's going to be a lot more dead bodies unless we learn to take care of people. And don't tell me we can't afford it, because my son, what he needed was about $1,000 a year in screening tests to prevent cancer. When we said no to that and he got cancer, taxpayers, you and I, paid $1 million for his care, and he died without being able to repay any of that. When you take care away from people, they die. That's what happens. Don't you dare say this is great, then call yourselves pro-life, because you're not. When people can't get care, people die. That's reality. I can never get my son back, but I will fight for your lives. I will fight for every one of your lives. And this is a travesty. This is privatization of life-saving services. Somebody's going to make a profit off of this. Whose kid is going to die next?
Good afternoon, my name is Calvin Thompkins. I'm a pediatrician with Asheville Pediatrics in town. I've been practicing there for 8 years. Just this morning I saw 14 patients before noon. 9 of them had Medicaid. I'm going to tell you about 3 of them. I'm using made-up names so nobody has to worry about patient confidentiality. I saw Nathan, who's a 15-month-old boy who's been doing fine. He's always done fine on his developmental screens, and it seemed like he was doing great at 15 months. Until I started speaking further with Mom about some of her observations, and it was through the course of the conversation that a preponderance of subtle observations gave me enough reason to make a referral for CDSA for a full developmental evaluation. Gabby is a 3.5-year-old female, and I've been speaking with Mom over multiple visits over the past 2.5 years to catch her up with her immunizations, and she hasn't had any immunizations since she was 4 months old, and has skipped most of her child checks. So she came in today, and I had another chance to speak with Mom, and I spoke with her for another 9 minutes about the importance of vaccines and how I think that was the best way to care for her child. And while she came in there having decided that she wasn't going to move forward with vaccinations, I was able to convince her after that final conversation to catch her up, and she received 5 shots and immunizations towards 9 different preventable diseases. Molly is a 6-year-old female who is new to my practice and newly in the foster care system. She had her first day at her new school in a new county yesterday. She had her first dental appointment yesterday in her life, and she was seeing me for the first time today. I didn't have any medical records or immunization records, and what I'm going to do now is rely on CCNC with the help of DSS to round up those records so that I can properly take care of her. If Molly is like many of the other foster care patients I see, she's going to see multiple different PMDs in the next several months to years, and CCNC is going to be the one to provide wraparound services. Inserting MCOs into the Medicaid delivery system requires 2 things. For an MCO to operate, they need to make a profit, they need additional administrative costs. The easiest way to do this is to ration services or to decrease payments to providers. Providers faced with this choice will have 2 options. They can stop seeing Medicaid patients, or they can see more Medicaid patients in the same amount of time. The result, Medicaid patients will be getting less attention. There'll be fewer Nathans getting timely developmental evals, fewer Gabbies getting caught up on immunizations, fewer 6.5-year-olds with the help of CCNC getting wraparound services for foster care. The legislature passed this waiver with the idea of getting budget predictability. CCNC has helped North Carolina lead the country in containing Medicaid, the rise of Medicaid costs, and the legislature also wanted innovation. I work with Mission Health Partners. We're following 15 pediatric practices, 15 family medicine practices across 35 data points. We have pilots that is promoting breastfeeding. We delivered 3 tons of fresh produce to food insecure families in the first 3 months of a pilot. We've got the innovation. We've got the budget predictability. We don't need to change the system. Work with us to make it better. Thank you.
Ditto that, Dr. Thompkins. Thanks very much. My name is Richard Hudspeth. I'm the practicing physician and the CEO and Chief Medical Officer of Blue Ridge Health. We're a community health center in Western North Carolina. We have 15 different sites, take care of over 30,000 individual patients in 7 different counties in North Carolina. I could touch on every single 7 issue that you listed here earlier with multiple things, but I've got to narrow myself down to 2. So the first, I'm going to just mention a very specific point related to community health centers, and that's issue number 6, which is paying for value. One of the primary avenues by which the 1115 waiver transformation proposes to implement paying for values through a delivery system reform incentive payment, or the DSRIP. However, the 4 proposed delivery system reforms leave out the primary care safety net, which includes community health centers, which includes our charitable care clinics, as well as our rural health clinics. So please look at that and make sure that we are included in that. Include all essential providers in this legislation, and that will ensure that there will be greater emphasis on preventative and primary care. Please also make sure that these essential providers provide leadership roles in the decision-making body. My last comment I'd like to make is related to your desire for information on physical and behavioral health integration. Community health centers across the nation and in North Carolina have been on the forefront of doing this. We have had much in our innovation and integration of that, including our medication-assisted therapy treatment program for folks that have opioid use issues. Please go and learn from those systems that are out there, what they do well, and make sure that the managed care environment supports those initiatives. I ask you to ask yourselves, what in a managed care environment that we've seen so far in the United States has supported those initiatives? Please ensure parity, financial support for integration. Avoid the barriers such as limits, prior authorizations, and even a separate payment system for these things. Furthermore, I want to relate some of what we're doing with our substance abuse issue that we have in this country. And I refer back to something as simple as what Benjamin Franklin said. An ounce of prevention is worth a pound of cure. And we must and continue to spend on the pound of cure. And we are continuing to do that, but where is our spend on the ounce of prevention? One way that we are innovating with that is with school-based health centers. So we are allowing teachers to teach, kids to stay in school, and parents to stay at work. And so please think about, again, how does this managed care environment support an innovation such as a school-based health center in order to provide behavioral health care for those children in our school program. If we're going to want to prevent the problem of opioid use, we have to have an ability to give our adolescents a different tool set in order to combat the so easy, here's a bottle of beer or here's a bottle of pills in order to make their problems go away. So please think about how this environment is going to support innovative efforts like that. Thank you very much.
Good afternoon. I'm William Keller, the Emergency Services Director for McDowell County, and also representing the North Carolina Association of EMS Administrators today. EMS providers in North Carolina form a safety net for the medically fragile and disadvantaged. Most of the EMS providers in the state are local government-based providers and rely heavily on fee-for-service to fund the essential functions of an EMS system. The previously filed waiver application, also known as the Section 1115 demonstration, must continue to provide North Carolina counties that run an EMS system the North Carolina Medicaid cost report settlements that provide over $35 million annually to government-based EMS agencies across North Carolina. These are federally funded dollars. They are administered through the state repository and hopefully will continue whether through the current model or through block grants. Opioid crisis continues to hit and affect every county in North Carolina, and EMS is at the forefront of this crisis. Just in McDowell County alone, overdoses contributed to opioids are up over 100% in the first 4 months of 2017. We have to have alternatives of care for patients with substance abuse disorders, and this includes getting them into harm reduction strategies, acute inpatient detox, as well as the formulation of rapid response teams, and allowing EMS the opportunity to transport to alternative destinations for patients who meet the criteria. As we know, the emergency department is not the place for these types of patients. We also need funding for Narcan and assistance with the price control of this life-saving medication. And finally, innovation across North Carolina is being driven by EMS in the pre-hospital setting, as community paramedic programs all across the state are proving that there is a better way to provide emergency medical services by trying to prevent the 911 call and be proactive instead of reactive in a 911 setting. These programs are geared towards decreasing hospitalization of citizens with mental health and substance abuse issues, reducing hospital readmissions, and targeting at-risk individuals by providing services in the patient's home by taking a holistic approach and working in conjunction with multiple community partners. We ask for the Medicaid program to consider funding additional types of services to include coverage and incentives for services offered by community paramedics. Thank you.
Hi, my name is Maggie Adams. I manage a grant, an initiative in Buncombe County called the Community Centered Health Home that is a cross-collaborative of healthcare, community nonprofits, and community residents living in public housing. In Buncombe County, we know that African American babies die at 3.1 times the rate that white babies died. And this is just one of the many health disparities in this county, state, and country. In order to address disparities here, we need to consider the social determinants of health and the effects that structural racism has on health outcomes. Two evidence-based strategies that we know address both of these factors are, first, the reimbursement of community health workers who help to address access to care and improve health outcomes. The second strategy is the reimbursement of pregnancy and postpartum doulas, which we know doulas have evidence-based outcomes to decrease preterm and low birth weight infants, which are major factors contributing to infant mortality. I also strongly urge you to consider expanding Medicaid. Many mothers lose pregnancy Medicaid 30 days, or all mothers lose pregnancy Medicaid 30 days after their babies are born and have no support after. Thank you.
Thank you for the opportunity to speak today. My name is Mike Sink, and I've worked in the field of developmental disabilities for over 20 years. Eventually, working up through the ranks, I was able to serve as the Executive Director of Economic Force Industrial Services. We served 80 individuals, learning job skills and finding employment in the community. Many of those folks are still working today. They're now taxpayers and they're active parts of that community. I also served as the Executive Director of Liberty Corner Enterprises. We enable people who were dually diagnosed with developmental disabilities and mental health challenges to move out of institutional settings. If you venture to the drum circle tonight downtown, yes, it's Asheville, we have a drum circle every Friday. You'll see many of those folks, and they're not sitting on the sidelines. They're part of that community, and they're well known there. The advantage I had in both of these organizations is that I worked with boards of directors that were local, and I worked with leadership from a managed care organization who was also local. The partnership between local boards of directors, nonprofits, and locally run managed care organizations means that when funding is tight and times are tough, we can come up with creative solutions. It's hard for me to imagine those same collaborative outcomes with a large insurance corporation, a hospital group, or anyone not based in Western North Carolina. Many of the innovative things happening for people with disabilities in our community are happening because Western North Carolina foundations, counties, funding groups, and area businesses support them. And if we lose that local connection, we lose that support. Thank you.
Is anyone number 9 or number 10? Oh, yeah. What number? 9 or 10?
My name's Laura Buchanan. And I was in a car accident last July. and I've been sitting here for 30 minutes, and I've been sitting here, my brain is starting to short circuit. So I'm having trouble communicating and walking right now. But the state of North Carolina feels that I'm able to work, so I cannot get assistance. I would love to return to my life and be able to work. I loved working. I've worked since I was 14 years old. I appreciate the accomplishment of working. I appreciate giving back to society, and I can barely stand here and do this right now. Any one of you would not want to be me today. When I think of medical care, I think of the phrase, do no harm. Me not being able to give proper medical care is harming me. And I just ask for fairness. I'm not asking for special treatment. I'm asking for fairness. I've worked since I was 14. I'm 53 years old. I deserve that fairness. I deserve that, and anyone like me does too. I don't deserve to be punished.
Amen.
And I want this expanded Medicaid. How in the world, if I don't make, I think it's $11,800 a year, how in the world do I pay $800 a month for insurance? The insanity of that is beyond me. And I've been denied Medicaid twice now, disability once, and I will continue to fight and stand up for myself till the state of North Carolina hears me. That's what I'm going to do, but I should not have to be traumatized with that fight. I think we all deserve fairness. Thank you.
My name is Elizabeth Buys. I'm an OBGYN here in town. I've been here since 1999. I'm very grateful for the opportunity to speak today and also for the opportunity to work in this community. I'm part of the safety net and participate in safety net care for women of this county and the 17 surrounding counties. And I'm very concerned about the health disparities that we see for women of color and babies of women of color. In terms of the goals to improve quality care, I'd like to speak to 3 things that I think can make a huge difference for my practice and the patients that we serve. The first is to continue to support, value, and help pay for collaboration and communication within care providers. One of the things I do almost at the end of every single day is try to connect with my patients, other physicians who are caring for them. And that time and energy has never been valued in a way that really continues to support our collaboration. Also, I think it's very important as a second point to ensure that as we collect quality data, that we put that quality data in racial and ethnic terms so that we can see what disparities exist and we can acknowledge them and try to support ways to fight against them. Our patients and our providers sometimes struggle to trust the healthcare system that we're in. As we continue to try to decrease health disparities, which will happen in my career, I think that we have to recognize that patients and providers need to be trained and understand implicit bias and institutionalized racism, both within the healthcare system and within the other institutions that we work within. Thanks very much.
Good Good afternoon. Thank you for the opportunity. My name is Michael Mabey. I'm the president of an organization called Watauga Opportunities, a nonprofit provider for IDD services in Western North Carolina. We provide services from Wilkesboro to Boone and from Boone down to Asheville. We cover the western 10 counties, northwestern 10 counties. I'm also a past member of the North Carolina Commission for Mental Health Development, Disabilities, and Substance Abuse, and also a commissioner for the North Carolina State Rehab Council. Been involved in this field for over 30 years and have been part of state associations representing people with IDD for those 30 years. We want to make certain that we seriously look at review and repair versus repeal and replace. Within our LME-MCO system, within our division of MHDDSA, we must not one more time, we must not repeal and replace. We cannot do that. We have to review and repair. We have been exhausted through change. Our providers are exhausted through change. How many times can you plant a crop and knock it down before the harvest? And then you plant again and knock it down before the harvest, and you plant again and knock it down before the harvest. What happens is eventually your land will no longer produce a harvest. And that's what's happening. We get halfway through a change, and then we knock it down before we get to the end. There's nothing to harvest, and we go into another change. We're exhausting our providers. We're exhausting our service recipients. We need to look at the local system we have that's responsive to our needs. My organization has placed over 1,100 people in competitive jobs in the community, people with intellectual developmental disabilities who were considered non-able to work. We've turned those tax receivers into taxpayers. They have a meaningful job, they have a meaningful week. That is because of the local control. That is because of VIA and what they've done in their responsiveness to our local needs, our local county commissioners and their responsiveness to our needs and our population's needs. We started this back in the 80s, and at that point in time, it was a long way from Boone to Raleigh. And we were far enough away so we didn't have to ask for permission. We just begged for forgiveness afterwards. And we developed our system on our own with our county commissioners and our people with local control, and we made it work. I'm concerned that if we start bringing in too many large corporate providers, that we will lose the responsiveness that local control offers us. I'm very, very concerned about that. And in terms of today's, on the larger scale, again, in today's medical world, we really do not need to repeal and replace. We must review and repair. Thank you.
We're ready for number 14. Do we have a 13? Oh, thank you.
Good afternoon. My name is Deanna Lamott. I am a former teacher turned public health professional in this community. And I just want to reiterate what some others have said already about the importance and the potential of local innovation, and to make sure that any changes in our Medicaid system and healthcare system focus on funding promising innovations and more community-based work that we know improves outcomes for low-resource people in communities of color specifically. One that people have mentioned before is community health workers that go into communities to increase access, to educate and partner with clients who otherwise would not have those resources. Another one is something that's happening locally here. There's a local FQHC in Hendersonville who has been doing for the last 5 years group medical visits for their highest utilizers. They're providing timely and responsive medical care with very few barriers, plus care management, behavioral health, and a safe, predictable environment where these highest utilizers can get social support as well, peer support. And that model has reduced the utilization in these patients 50%. And 2/3 of them are more functional now, have a higher functional score. We know these things work. Another thing is the emerging opportunities around engaging clients in conversations and interventions that address adverse childhood experiences. We know that adverse childhood experiences is a huge, huge risk factor for opioid substance use disorder, as well as diabetes and heart disease and anything else that we can think of. We know prevention and local engagement addresses and increases positive outcomes. And right now, all of the things that I'm talking about only exist because of short-term, grant-funded projects. None of these things, even though we know they work, none of these things have any sense of stability or sustainability right now. And our system has got to recognize that not everybody fits into the same system, the same mold. We have to have a system that actually responds to individuals and to communities' needs. And one last thing, I support expanding Medicaid. I have 3 personal, very close friends who would be dead right now without quality health care coverage. Thank you.
Good afternoon. My name is Susan Mims. I am a pediatrician and the vice president of the North Carolina Pediatric Society. And I am so glad that you all have asked us what's important for a successful Medicaid program. As you know, children are 70% of the recipients of Medicaid, but account for a much smaller percentage of the costs. And so sometimes their issues are at risk to be a lower priority. In many states, healthcare reform efforts have focused only on immediate savings, but we know that investments in children yield great returns, but over a longer period of time. As you consider how to approach changes to Medicaid, I urge you to keep children, our future, in the forefront. To ensure that pediatricians continue to be involved in defining North Carolina's quality metrics, indicators, and reporting, and that these must include the American Academy of Pediatrics evidence-based Bright Futures and the early periodic screening, diagnosis, and treatment, or EPSDT benefits. Access to care with primary care providers and subspecialty providers is at risk if the complexity, the administrative complexity or burden increases or if reimbursements decline. We're already facing a shortage of pediatric subspecialists with long waits because the reimbursement doesn't cover the cost of the care. And we know that healthy adults grow from children in healthy environments, and that we need to address, it's critical that we address the social determinants of health early, and that we ensure access to health care for parents, caregivers, by expanding Medicaid. This results in healthier North Carolinians of all ages. So as we create a Medicaid system to meet the needs of our states, I encourage us to heed the words of Frederick Douglass when he said, "It's easier to build strong children than to repair broken men." Thank you.
Hi, I'm Stephanie McGarrett. I'm a vice president with the North Carolina Hospital Association, and I wanted to thank you for the opportunity to provide input, both now and through the written process, which our member hospitals and health systems are working to develop a response. In the meantime, we did want to share with you that we have a long history of partnering with the state to develop and implement innovative payment and care delivery systems to ensure that access to high quality hospital services for all North Carolinians. We are committed to and look forward to working with you to continue that partnership. We also support ongoing efforts to maintain and expand access to insurance coverage, and we commend Governor Cooper and Representatives Lambeth and Dodson, among others, for driving those efforts. We support moving to whole person care in which physical and behavioral health conditions are addressed. The current behavioral health financing and delivery system needs improvement, especially for our patients and caregivers. We urge you to ensure that integration is real and effective. There will be a balance that will be difficult to achieve between administrative simplification and our ability to innovate. And we heard comments earlier about innovating locally, which we also think is very important. But please know that multiple MCOs with different provider enrollment, prior authorization, and other requirements create administrative burdens on patients and providers and may limit our ability to participate and therefore may limit patient access to care. Medicaid and the DHHS will need to develop new skills and capacities to oversee these plans effectively. We are glad to hear of your commitment to learn from other states and their implementation of managed care and to ensure that you have the skills and capacities in place prior to implementing any reforms. Hospitals and health systems are open all day, every day, providing care for all, and we look forward to our next steps in partnering to meet the needs of all North Carolinians, particularly our most vulnerable citizens. Thank you.
Good afternoon, my name is Greg Borum. I'm Director of Advocacy for Children First Communities and Schools of Buncombe County. I want to thank DHHS for coming out west to hear our comments today, and also I'm so encouraged by so many folks in the room getting up and standing and sharing their stories, so thank you for being here. Children First Communities and Schools works with children and families in schools and the community to help them prepare and do great things in life. A lot of the children that we work with rely on Medicaid or NC Health Choice for their health insurance and care. And we also do a lot of public policy advocacy and focusing on things that would be considered social determinants of health, like transportation, child care, food security, and housing affordability. We understand that those issues do have an impact on child and family health, and I'm very encouraged to see DHHS asking for input on that. I don't have the answers on how Medicaid can integrate, but I think keep asking those questions. We want to see those links made. Those are important things to look at. I do have concerns that as we move forward with this Medicaid reform, that we will be back here fighting for just keeping the care where it is right now. There's folks have already talked about concerns about where the money will go and how we'll roll this out, and we cannot afford to let slide any of the coverage that we have, the comprehensive services that we are providing to children through Medicaid, and we need to make sure we hold the line on that so that we can truly move forward and try to do some innovation and build on the great progress, especially some of the work that's happening here in Western North Carolina that have been talked about. And finally, I'd like to call on North Carolina to expand Medicaid. We've waited way too long. So many of the faces in this room, we've been a broken record on this issue, and we're ready. I want to just make the case that this is a critical issue for children too, because we have about an estimated 500,000 adults who might qualify for Medicaid expansion if we did that. About 100,000 of those are estimated to have children at home, and by covering adult caregivers, it brings up outcomes for better health for their children. Thank you very much.
Hi, my name is Jane Lindsay. I'm the guardian of a young lady who was a shaken baby at the age of 7 weeks. She is extremely medically fragile. She came into the CAP program in 1992. In the new innovations program, there is only one service that will meet her needs, and I'm extremely concerned that the state isn't addressing the needs of the truly medically fragile adults that are in this state. In the past year and a half, I've had 5 appeals. One was for a wheelchair. She's had 3 wheelchairs all of her life. It was denied because she's small, and she needed an adult chair, and a pediatric chair was what was needed. It took a year to get that. She was denied a bath chair on the same premise. I went through 2 appeals for medication, one for an antibiotic that she went 3 weeks without getting when there was nothing else to replace it. One was a pain medication. I went to that appeal with an empty bottle of pain medication, the same bottle that had been approved the year before. She went weeks without her pain medication. She has malabsorption. She weighs 40 pounds. She went 1 year without nutritional supplement without me buying it because Medicaid would not pay for it. I went to 5 appeals. All 5 appeals were won. Her doctors had to go through an extreme amount of time and energy to write the letters, to be there to back me, to go through medication appeals. It's time to cut some of the red tape and get these medically fragile adults and children the care that they need without having to go through endless appeals and endless prior approvals. Because if they need it, they've tried the generic, it hasn't worked, and year after year I go through prior approvals for the same medication that she's taken 20 years. Thank you.
Hello there. My name is Tammy Gray, and I have been working with the Medicaid population for about 27 years. I'm currently working with Via Health as a housing specialist, and I have about 60 folks in my program with families that we are serving and also working to help them succeed on their own in the world of that ever changes. I think that it's very important for me and for all of us to promote significant improvements in the behavioral health system as it moves into hopefully a more recovery-based managed care delivery model. For people with severe and persistent mental health and addiction, it is important that we are designed for people with serious mental health conditions and substance use disorders that covers all benefits provided by Medicaid managed care plans, including expanded behavioral health benefits, and also providing additional specialty services to help people live better, go to school, work, and be part of the community. I know that all of us in this room, whether or not we have good health coverage or not, most of us probably do, but we all share something in common, and that is having family members or people that we love that may not have as many things as we do. And in that process, many people are trying to recover from addiction. Maybe some folks don't know how to do that. Within my 60 families that I serve, I have seen a lot of wonderful things that have happened in their lives. Many of them are recovering, many of them have their children back, they have their families, they are working on their lives, going to school, now trying to work, and that's a huge accomplishment. But they could not have done that without the housing grants that have been made possible for Via Health to manage. And because of that, they actually have their lives back. And you know, we all, whether or not we have those folks in our families or not, our children are on the roads. I have a 16-year-old son and he drives. We all drive all the time. And sometimes we don't really think about that person that's coming toward us in that other vehicle. You never know, that person that's coming toward you may not have insurance, but yet they want to have help with their addiction. And I really don't want to see someone hit my child or hit somebody that I love because they didn't have an opportunity to get what they needed in recovery. And I think a lot of that goes back to Medicaid and state funding, and it's so important in all of our lives to make sure that we just stand up for what's right. We all need to do what's right, and that's not always the easy thing to do. It's usually the very hardest thing to do. But remember, that person that is passing your kid or passing your mom or even passing you, they may not have the insurance that they need. So thank you for listening.
Hello. So I'm number 19, just so number 20 knows. My name is Mary Short. And hi, Dave Richard, nice to see you. And I've forgotten your name already.
Kristen.
Kristen. I am thrilled you are here, Kristen. I'm thrilled to hear you worked at CMS along with Secretary Cohen, who comes to us from CMS. So we're going to play a little game. Once upon a time, there was a parent of a 37-year-old adult female, single parent, with severe and profound intellectual and developmental disabilities. And this parent has spent the last, 18 years trying to figure out what's wrong with the 1915C waiver for severe and profound individuals. And this parent, again, in this once upon a time scenario, discovered that this state has not taken advantage of all the Medicaid that's been available to it. Now, there's this new secretary in this pretend world that comes from CMS. And as the gentleman from Watauga Opportunities spoke about, the idea in this pretend world that this secretary is going to review and repair the 1915C waiver, that sounds like hope to this parent and the adult involved. One of the changes that the parent would like to talk about would be we should change the definition of intellectual and developmental disability. CMS only requires that the definition of state use not be more restrictive than the federal definition. So this idea of the 10-year wait list for individuals, adults with intellectual and developmental disabilities, and remember, they didn't know they were going to be born that way. It's not like they, had anyway. So, if we change our definition of intellectual developmental disabilities and the level of care for ICFMR in the intermediate care facility, mental retardation, if we change that definition, we could help those 12,000 people on that wait list that Medicaid expansion jumps over. So those 12,000 people on a waiting list are a little annoyed at the idea that they're just going to be jumped over by Medicaid expansion to non-elderly, non-disabled, working age adult men. It's offensive to us. We also think there needs to be a review of long-term services and supports. CMS always includes IDD individuals when it talks about long-term services and supports. This state in this pretend world has somehow moved IDD individuals into a separate silo. So we would like to be included with the CMS definition of long-term services and supports if in this pretend world the secretary was going to review and repair. And we'd also like a review and a repair of the policies regarding workforce in this state. And in the real world, this parent of an adult never agreed with the MCO system for the IDD population. We are a tiny percentage of people in North Carolina, and to have one statewide system where we are all treated the same would be really fabulous. So I thank you for your time.
I'm Bob Carey. I represent the Yancey Mitchell branch of the NAACP. Over a year ago, when the hearing was held on this plan, I made two recommendations for that group. The first one was that the Department of Health and Human Services make the record of these public comments public, along with how these comments were dealt with. And this was done, and we appreciate it. That's really a helpful thing. You can go to their website and see how they addressed everything. The second thing that we recommended was that North Carolina close the Medicaid coverage gap. Medicaid so this is as important as it ever was, as so many people are saying. But this proposal only covers about 30 to 40% of the people that it should cover. In Yancey County and Mitchell County, the Yancey County Board of Commissioners, the Yancey County DSS Board, the Burnsville Town Board, the Toe River Health District Board, the Bakersville Community Health Center, the Seal of Friends Meeting, and the CLO Health Center Board all passed resolutions to close the Medicaid gap and send them to the legislature and the governor. I want to read something real quick. In the plan, it's the executive summary, and to me, when I saw that, I really understood what was going on. It says, North Carolina Medicaid reform demonstration represents the culmination of 3 years of stakeholders' engagement and planning to accomplish the joint vision of Governor Pat McCoy and the North Carolina General Assembly. And that's just what the vision did. It's not the people's vision, it's part of our legislators' vision. We need the people's vision. Thank you.
Thank you for this opportunity to speak. My name is Rebecca Love. I'm a family physician. I've worked in hospice and palliative care in the community, participating with CCNC on projects to reduce costs and improve care. I've worked with many complex Medicaid patients in Cleveland County. North Carolina Medicaid reform should help us reclaim the power of the relationship between primary care physicians and patients. Physical and psychological health are entwined in ways that we don't fully understand. We can't hope to solve problems like the opioid epidemic or other epidemics coming our way by trying to separate medical and behavioral treatments. Make primary care practices the hubs of integrated care. Combine the work already done by the American Academy of Family Practice on their recent proposal for advanced primary care, an alternative payment model, with work done across the country on models of integrated care and behavioral health to develop unified community-wide collaborative practices across the state. This could incorporate other areas besides behavioral health where there are gaps in care or special needs. Use CCNC expertise to train care coordinators and communicators in each practice to listen and communicate among various providers to form the link for this integrative care model and use the current behavioral health partners in these primary care practices. Invest in secure communication methods for all participants to allow flow of information to and from primary care practices, regardless of what system of documentation is used by each or what hospital system patients end up in. Allow Medicaid patients to choose from these participating practices. Study the AAFP's proposal. It covers all the questions under the topics of concern today. Barriers and risk metrics and data for assuring quality and cost savings, and addresses ways to reduce administrative burden on physicians. The AAFP payment model allows initially for 2 levels of prospective risk-stratified global payment directly to physicians providing this comprehensive care. It does not involve another layer of administration for a managed care that just adds cost to our system. This could be expanded to include a third component of prospective payment to specialty partners to encourage providers to develop partnerships and communications that are the essence of true integrated health models to cover special needs or gaps. Try the APC-APM in a few pilot communities where risks are high or gaps in care are large. This model will stretch resources further to touch more lives in beneficial ways and be efficient and satisfying for physicians and patients. Thank you.
We have a number 22. Could we get 22, 23, 24, and 25 to come down front, please?
Oh, good God. I'm 25. This is not fair.
Good afternoon, everyone. My name is Jackie Kiger. I am an attorney with Pisgah Legal Services. Pisgah Legal Services believes in equal access to justice, and our focus is on helping low-income individuals and families across Western North Carolina meet their most basic needs through civil legal advocacy. So we're focused on affordable, stable, quality housing, safety from violence and abuse in the home, and access to health care and quality health care services. I am really grateful to have the opportunity to be here today to speak on behalf of the many clients that we serve and the issues that we see every day in the legal system, many as a result of people who do not have access to healthcare services. It is critically important for all North Carolinians to have access to quality, affordable, meaningful coverage and healthcare services. And so for me, the questions posed by the department are very good ones, but I can't really speak about reform unless it is also talking about expanding coverage and closing the coverage gap. The ultimate goal of improving the health and the quality of the lives of all North Carolinians, we first have to provide an opportunity for all North Carolinians to have the access to this coverage and the care that they need. Closing the healthcare coverage gap is one of the best ways to really make a change. And this gap, as we're talking about, these are the more than 500,000 people here in the state who are too poor to qualify for financial assistance and get coverage in the private insurance market through the ACA, but do not meet any of the definitions of the categorical eligibility for Medicaid under the law as it stands right now. So I argue that this be one of the very first steps that we make, this critical step to achieve these overall goals and to lead us as a state, a region, and a community down a path of improved health. And some of the facts that I want to lay out before us. By reducing the number of the uninsured, we will include many more working families and veterans. We heard from the pediatricians about how important it is for good quality care for kids, but let's not leave out their parents and their caregivers. We can equip North Carolina more to address this opioid epidemic that is happening right here in our community. We know that Medicaid has the ability, it's an effective tool at addressing that, but when people don't have access to the coverage because they are left in that gap, it is one less service available to them. We can increase low-cost preventive care and preventive screening so that people can avoid costly, acute, chronic health conditions and going to the emergency departments. We can promote financial security for people who are facing medical debt. And I say this from experience. The stress of medical debt, the fear of losing your home, being evicted because you can't pay your rent, not being able to feed your kids, it is devastating. It is just as bad as going through the medical crisis itself, but going through both of those things together is unbearable. My first several years as an attorney at Pisgah Legal Services were focused on helping people who needed to access disability, fighting for them for their eligibility, and doing this work. We see so many social issues that are tied up with the ability to be healthy. There's an opportunity for real innovation here and looking at many, many ways to do this, but closing the coverage gap is the first thing we need to do. I hope that today is the first of many opportunities for those who are on Medicaid and hopefully for those who will be, along with providers and their families, to have an opportunity to talk about their needs and experiences. Thank you.
Man, I don't want to follow Jackie. I'm Amanda Murphy. I'm one of the OBGYN providers in this area. I take care of the majority of Medicaid patients. Louder. One of the OBGYN providers in the area, and I take care of a majority of Medicaid patients. I do not pretend to know everything about Medicaid, but I do know what I see in my patients. And I know that they get Medicaid while they're pregnant, and then once their pregnancy ends, after that amount of time, they cannot come back and continue to have a relationship with me and have the families that they want or prevent maybe future children they want because they no longer have Medicaid that will pay for their birth control. I want to ask you to support innovative programs for healthcare like Centering Pregnancy, which is a group prenatal visit that allows us to be in a relationship with one another. And the way that that's different from one-on-one care is that the women, the wise women in the group, the families are the ones in charge. They're the ones who are providing the information and we're just listening. And then if you follow a thread like that to things like what my friend Maggie talked about with doula services and community healthcare workers, then those women can go on feeling empowered from their prenatal care after their birth, and then increase their access to come back to the people they have a relationship with. So what happens when you listen to your patients? You go from being in charge of their medical problem to being in relationship with them. And so if you expand Medicaid, they can continue to do that, and then you can actually learn from the people you're trying to take care of. Thank you.
Hi, my name is Sheree Novak, and I am a parent advocate. And I will talk a little bit about history. A couple years after my son was born, he was diagnosed with autism. And I knew that he needed more support, so I worked to get him on the Medicaid waiver program. He was on the wait list for about 3 years, got on, and he started improving right away. So then there was a movement to remove people like my son who was improving. And so I filed an appeal, and I was lucky. I did have an attorney to help me. And just as we were about to win our case, that's when I found out that a provider who was put in our home did some unspeakable things to my son. And as a result, my son was hospitalized 13 times in a year and has been hospitalized every year up until, I think it was 2010, when the second piece, well, three things I want to talk about. First is when they were going to take him off of the Medicaid waiver, and I walked into the hearing room. The people that I thought were there to fight for me were the state, and they were fighting against me. And so at that point, I became an advocate to get independent support people, independent advocates. We got it, then it was taken away, and it's never been brought back. And when I die, who's going to be there for my son? You know, we need that more than probably anything else. We have to have people there to fight for us. Two is, after my son went through this horrible thing, we could not get staff to work for us for the measly amount of reimbursement. And at that time, there was something where it was, you got a little bit more money if you had a situation that was more difficult and it was behavioral. That was taken away. That's not been brought back either. So at this point, I'm providing services because nobody else will do it. It's not easy to work with people who have a lot of different issues, especially emotional. There's no training, there's no vacation, there's little benefits from doing this. The third thing I want to talk about is managed care. I started getting Social Security, so my son went on as per, somehow he ends up on Medicare. So now we're on managed care. And the psychiatrist he had does not accept Medicare, so we will lose that. The therapist does not qualify under Medicare, so we're going to lose that. And we were already told that one of his medications is being taken away. The psychiatrist wrote a letter, and he'll get it for a year, and then we have to do something else. So I'm not sold on managed care. And so I hope when we look at this, there are three things. We need an independent representative. We need to take care of the people who are actually providing services for folks. And managed care cannot be one size fits all.
Good afternoon. My name is Matt Cannon, and I have a very concise message. I really appreciate everyone coming out today and sharing with DHHS all these wonderful, amazing stories. I've worked in Western North Carolina in Buncombe, McDowell, Madison, Mitchell, Yancey counties, and my work right now is currently focused in the northern counties, Ashe, Wilkes. Having worked in so many rural areas of this region, I know firsthand that it is vital to maintain a local presence in the management of services for mental health, substance use disorders, and intellectual developmental disabilities. I'm here today because I want to advocate that you consider a special needs plan that builds on the managed care organizations that already exist in Western North Carolina. The fact of the matter is that each town and city in our area has unique needs, and they deserve to have access to high quality care, especially considering these most vulnerable populations. Marion is different than Boone. Boone is different than Spruce Pine. Spruce Pine is different than Franklin. I'm advocating that we build a special needs plan based on the infrastructure we already have that is working effectively and that is stable with the LME MCO system. We have to find a way to do what is right for individuals and their families. And an important consideration in these small communities that I just mentioned is maintaining local control. Thank you for your time.
We have a number 28, 29, 30, 31, 32. If you'll all just come on down.
Hello, everyone, and thank you all for giving us this opportunity to be able to be here. I'm Michael Woods. I'm the Executive Director of the Western Carolina Rescue Ministry. We're the largest emergency shelter in all of Western North Carolina. We see the brunt of the vulnerable population. I am also the chairman of the board of the Appalachian Mountain Community Health Center, which we actually have a clinic embedded in our shelter that serves the brunt of the homeless population here in Asheville. One of the things that I would like to say, especially since this is a listening session, and my hope is that you all actually will listen and not do things as normal. I was talking to my 96-year-old grandmother the other day, and we were talking about healthcare, and she was kind of upset because of the so-called repeal that's kind of taking place. And we were talking about this, and she made this statement, and this is something that I've heard my grandmother say for years. I'm a great God-fearing woman. And she said this about the healthcare system in America, and she said they are going about it ASS backwards. and she's absolutely right. See the so-called expansion of Medicaid and the way that we're looking at doing it, we're starting about it the wrong way. The politicians are looking at it from a funding standpoint. But the right solution should come about considering the people first. If we start there, then we're going to get it right. See, we need to do what's right because it's right. Period. And so making sure that everyone in the state has access to proper care should be first and foremost. Then we'll figure out how to fund it. If we start looking at funding first, then we start eliminating groups of people. And no one should be eliminated. No one should be eliminated. So that's my first thing. Whoa, already? Wow, okay. All right, well, I'm done, I guess.
Good afternoon, I'm Rob Fields. I'm a family doc. I'm the medical director of Mission Health Partners, where a network of 8 hospitals, 1,100 physicians, and that are taking care of 80,000 Medicare beneficiaries and other beneficiaries, actually not just Medicare, across our 18 counties. I appreciate the opportunity and giving us the time to have a discussion, one-sided obviously, but at least to hear our thoughts as to what the plans are. I am actually excited to hear something positive about at least having a conversation around social determinants and upstream thinking and how we fund healthcare. I think we learned several things about healthcare in general and how we manage it in the United States, and one is that if you incentivize more widgets, you get more widgets, you don't get better health. And it costs us a lot of money to fund things in that manner. Similar to what was just said, we're funding a delivery system, we're not funding health for people, and those are two fundamentally different things. What we learned from the Affordable Care Act is that access saves lives. That to give somebody meaningful coverage is a life-saving event in and of itself. And that should really define how we approach things like Medicaid expansion. Because without even the opportunity for access, as was stated earlier, people will die as a result, and they do die as a result. So we should start there. The other thing we learned, I think, is that short-term, or the search for short-term savings is not really a fundamental way to fund healthcare. We need to think long-term and invest in people earlier, which would suggest that we have universal coverage lifelong. It is only in that way that we can actually get the return on the investment on those upstream approaches like housing, mental health. It's actually better for us and newer delivery systems, which is part of this conversation, to fund 20 community health workers is to fund 1 neurosurgeon. So it allows that conversation as we talk about social determinants. Ultimately, I'm sorry to not give any more time back to the gentleman that just spoke, but I totally agree that ultimately, I think what we learned from the Affordable Care Act is that doing the right thing actually saves money. You can have both, but you got to start with doing the right thing. Thanks.
Hi, my name is Erin Lorenz, and I'm an OBGYN here in Asheville. I work with women who have substance abuse disorders and pregnancy. Unfortunately, many of the women I see have coverage for both addiction and gestation through Medicaid because they are pregnant. Unfortunately, all of the hard work that many of these women put into recovery during their pregnancy is often lost when they lose access to mental health services. They lose the ability to obtain medication-assisted treatment. They relapse. They overdose. They die. They contract hepatitis C. They contract HIV. And then they get pregnant again. All because they lost Medicaid coverage weeks after bringing their new baby home. Closing the coverage gap, particularly coverage for mental health and addiction for women of childbearing age between pregnancies, is important, number one, because their lives matter and their children's lives matter. But their lives don't matter less when they're not pregnant. Secondarily, doing this would address many of the questions we're being asked today, including questions about doing everything possible to meet the coverage and access needs of North Carolinians addicted to opioids and other substances. In addition, whether or not a child's mother has an active addiction is a social determinant of health. We have a unique opportunity to affect at least 2 lives by expanding coverage by 1. Thank you.
Thank you for the opportunity to speak today and offer comments. I'm Dr. Elisa Nance, and I'm the Vice President of the North Carolina Academy of Family Physicians. The NCFP is the largest specialty-based association in the state, representing 4,000 family physicians, residents, and students. First and foremost, primary care must be the foundation of reform. By focusing on and investing in primary care, reform can lead to better outcomes for the patients, lower costs for the state and our taxpayers, and improve patient engagement and more physician satisfaction. We believe that it is time for North Carolina to close the coverage gap for those who remain uninsured in our state. Uninsured individuals cost the system by receiving care when diseases are more advanced and in settings like the emergency room that are more expensive. We support and applaud Representative Lambert, Representative Dobson, and Governor Cooper for seeking innovative ways to choose and close the coverage gap of our state. Social determinants of health must also be considered in the reform plan as well. For example, mold in housing triggers many costly ER visits for asthmatic patients. However, paying for home visits and emphasizing on the ground care of care management can help. And we must look to the individual conditions of individual communities across the state. Just because it works in Raleigh doesn't mean it will work in the western counties of North Carolina. We urge the state to require and use the existing care management program that's infrastructured now. Local care managers have existing relationships and trust with those patients and those physicians. Dealing with multiple care management and quality improvement infrastructure would be an undue burden. Medicaid reform must bring the head and the body back together. Integrating behavioral health and physical health is truly what the whole patient is all about. This means allowing primary care to provide the needed behavioral health services for their patients outside of the current LME MCO model. We appreciate this opportunity to comment and look forward to working with the department.
Y'all don't have to wait for me, so we're on 33, 34, 35, 36. We can fit you all up here. And then when you see somebody get up here and start speaking, just go ahead and keep on filling up the chairs. I guess you could go. All right. Good afternoon. My name is Sabra Ball, and I'm a licensed clinical addiction specialist and a licensed clinical social worker in Western North Carolina. And I've had the privilege of working in my home state and my home area since 1998 in some capacity with individuals with Medicaid or state-funded services or no insurances at all. And I worked my way up from 98 on into other parts of the system. So part of what I want to address is probably all three areas of the hat today, because my services are all across the spectrum. I've spent a long time working with individuals with intellectual and developmental disabilities, as well as people with mental health struggles in our rural populations, and women with substance abuse issues. And I echo probably the same concerns that everyone else in this room has in terms of the loss of Medicaid after pregnancy, the loss of services due to financial crises, and the loss of lives due to overdose. So I certainly believe in continued plans that we have to address all of the special needs here in our populations and for increased and continued work. I've lived in this area long enough and have worked long enough to realize that sometimes we have repeated crises. Back in 2013, I had the pleasure of working for the alcohol and drug abuse treatment centers here, and at that time we thought they would all close. And here we are again looking at similar crises as well. That creates fear. Fear for those of us working and fear for the individuals who need services. And unfortunately, fear sometimes drives some of the continued problems to continue. So I want to thank you all to have some good time consideration on how we can improve the plans that we have before we decrease all the services that we have. Lives matter. All of our lives matter in here, and all of the individuals that live in our area, their matters. Thank you.
Good afternoon. My name is Jesse Smathers. I think we're losing people because we skipped several folks to get to my number 37. So try to lighten it up a bit. I prepared some remarks and then I've heard what people have said. And nothing I had planned to say was worth saying after hearing everything that I have heard. One thing that's for certain is that we need Medicaid expansion. There's no doubt about that. 11% of people uninsured. But that's just uncalled for. We also need to improve system delivery in lots of ways, and I'm going to focus on the thing I know best, and that's intellectual and developmental disabilities. In this state, there are 12,678 NC innovations waiver slots. That's 12,000 plus people that live in the community that otherwise would be in an institution, the institutions we used to use. Right now, we have about 1,600 people living in 3 institutions throughout our state. We call them BD centers. We spend, and another 2,700 people living in intermediate care facilities for people with intellectual disabilities. We spend more money on that smaller group of people than we do all 12,000 plus on the MC labor. We also have about 12,000, actually probably 13,000 or more people waiting for innovation services. We need more slots, and we get more slots by closing the door on our institutions and bringing people into the community. Thank you for your time.
Thanks, Jesse, for speaking from your heart. My name's Don Buckner. I want to try to speak some from my heart. I grew up in this area. I grew up in Brevard, North Carolina, just a couple of counties over. I've worked here since 1996 in Haywood County West, and I'm a child psychiatrist. There aren't many of us around here, especially working out west. And I don't think we'll get many out there because there's a lot of barriers. Psychiatrists aren't allowed to directly enroll with Medicaid, which we are the only specialty that is not allowed to directly enroll with Medicaid. We have to enroll through MCOs, and I understand why, but it's really hurt us. There's a lot of barriers that could be removed, and there's smart people in North Carolina that if you were willing to talk with them through the Psychiatric Association, I'm the vice president, soon to be president of the North Carolina Psychiatric Association. There's some really smart people I call my colleagues there that have some nice possible solutions for some of these problems. Integrated care, everybody talks about, and my MCO tells me that I need to be doing it. The problem is I have to look for grant money. I have to look for free money in order to do it because our system right now won't pay me to do it. I am the MCO of my behavioral health agency right now. So I see the numbers, and it's frustrating to me that I have to go beg for money to do the care that I'm expected to do at this point through our agency. So the other thing that resonates with me as a behavioral health provider are two terms: change fatigue and institutional trauma. Our behavioral health system has gone through so many changes over the last 12 years that many people have left that system. We used to have psychiatrists that stayed in the behavioral health, community health system for 30 years and retired. I dare say there are many of us that have been in it more than 10 years now, and so many people are looking to get out of it because it just gets so more complicated. So we've got to create some incentives for people to stay there. So make it less complicated, make it rewarding to stay in that system, be able to pay people for the services that they receive, and expand Medicaid so we can do more of this good work. Thanks.
Good afternoon. My name is Brian Justice, and I'm a proud native of Haywood County, and it's a pleasure to be here today. I appreciate the opportunity to speak and to listen. Thank you. I have been a tax-paying citizen, working tax-paying citizen in Western North Carolina for over 30 years. And for 15 of those years, I've had the privilege of supporting people who have mental health issues, intellectual or developmental disabilities, or substance use disorders. And I'm here today to advocate for the expansion of Medicaid. The only chance we have to control spiraling, skyrocketing health care costs is through universal health care coverage for all. Otherwise, the uninsured are paid for by those who are insured. So I believe our costs will continue to rise if we don't close the gap. I'm also here especially to advocate for a special needs plan. I believe firmly that local utilization and review and local service delivery are the best tools to deliver this outcome, to achieve this goal. We've seen too many harvests wasted. We've seen too many mowed down. I believe, strongly that we need to use savings that have been generated through the MCO creations to fund additional services for additional people in need. I do not believe that the state of North Carolina should use these savings to offset state budget cuts. Thank you again.
Good afternoon. My name is Morgan Bost, and I'm with Children First Communities and Schools. This past Monday, May 8th, marked the 12-year anniversary of losing my brother to an opioid overdose. He was 21 years old. That particular day, May 8th, 2005, also happened to be Mother's Day. So while this weekend marks a joyous occasion for a lot of moms, for my mom and my family, it is met with a very different sentiment. I am calling for the expansion of Medicaid because I believe it is a critical combatant in battling this opioid epidemic. Not just by increasing substance abuse programs and education, but also because currently Medicaid provides critical health care resources to children and their families in our state. And as many people have mentioned before me, access to health care early on is crucial in ensuring that we have healthy adults. And as others have said before me, lack of access to medical care and exposure to adverse childhood experiences greatly increase an individual's likelihood of substance abuse. So if we really are serious about battling this epidemic, we need to expand Medicaid and ensure that our children and their families are getting the proper access to health care. Thank you.
Say that the passion and the wisdom and the experience in this room today is awesome, and I'm so glad that you're here listening. Thank you for making the trip out to Western North Carolina. My name is Jennifer Way Davis, and I'm the Executive Director of Community Care of Western North Carolina, a regional network of healthcare providers and care managers, community partners who together have been serving the state Medicaid program for 20 years, innovating and improving the quality of care for children, low-income adults, elderly, and disabled patients across our communities. We are one of 14 networks of CCNC, and we serve the 15 westernmost counties of the state. The $14 billion a year North Carolina Medicaid system is a critical resource that serves nearly 2 million of our citizens directly and indirectly impacts everyone in this state. Changes to this program should be weighed carefully and introduced deliberately. Our experience has shown us that Western North Carolina patients and Western North Carolina healthcare providers are a resilient people, ever adapting to the nonstop change in the healthcare systems that often literally define the quality of their lives. As the state prepares to implement more sweeping changes, we encourage you to consider the following. It is vital to maintain high provider participation in the North Carolina Medicaid program, and that those providers who participate in the care of this under-resourced population benefit from available, standardized support and reduced administrative burden across the prepaid health plans. A statewide practice support function like that in place through Community Care Now, including quality improvement, practice transformation, and care management for complex, high-risk patients is vital to maintaining high provider participation. The patients who rely on Medicaid for access to affordable, high-quality healthcare services deserve the standard of whole-person care. As someone before me has said, we must reconnect the head and the body. 43% of North Carolina beneficiaries with a behavioral health diagnosis are treated exclusively in their primary care offices, and primary care should be incentivized and reimbursed for the provision of behavioral health services. Likewise, patients need access to local care managers and care team members who know how to tap into services, as care management invariably requires an understanding of and connection to local community resources, such as food, transportation, housing, and financial assistance. The innovations deployed through Community Care and its partners has so far retained a maximized number of participating providers and contributed to a 3-to-1 return on investment to the state, making North Carolina first in containing Medicaid cost growth. On behalf of the patients and providers we serve daily, Thank you for taking the time to investigate and build on what is working in North Carolina.
Good afternoon. I'm Sarah Lancaster, and I've been in the field behavioral health for 14 years. And starting, it's a listening session. How do you get folks to really be mindful and to really pay attention to what you're saying? So I thank everyone today for really coming up here with your passion and your advocacy and really standing for what you believe in. And I also would just ask, I know you guys are taking notes and checking emails and all sorts of stuff that we have to continue to do, but really take a moment and in this minute, the decisions that everyone is making on a state level, how it is impacting the lives of everyone that is not here represented today. So I really want us, to really be mindful of the comments that are being made here today, and I appreciate the opportunity as well to share. So like I said, I've been in the field for 14 years, and I've seen various versions of reform to different degrees. And it is important for our members that are enrolled in Value Health or other MCOs to not continue to experience change. Our systems are complex enough as it is, and we really, on a local level, we really need to focus on building a special needs plan on what is already working. Everyone has come here today, are talking about collaborative efforts on the community and local and partnership level that are working, that we just have to continue to, like Michael may be saying with the harvest, continue to nourish it. The NC must find a way to do what is best for members, families, and our communities on a local level. We need to start listening to the citizens of our great state who are going to be impacted the most. Thank you.
45, so let's keep it right. I'm Janet Price Farrell. Thank you for coming here, our comments, and I look forward to seeing what you do with those comments. We want to see something different. I'm the Executive Director of First, a resource center for persons with disabilities and their families. And I'm also a parent advocate and a provider for services under Innovations Waiver. But I'm kind of here as a parent today. I've been to these forums. I have a 21-year-old on a waiver. I've been to these forums before, and I keep saying, you have been making changes since 2004 every 2 years. Stop it. Every time somebody gets something, we start getting the kinks worked out, you come by and change it. As a parent, as a provider, as just a human being trying to keep up with the names and the acronyms, it's beyond ridiculous. Every time you make a change, you add more requirements to a provider. Every time you make a change, you make it harder for a practitioner to do their job. They leave town. That's why we don't have child psychiatrists. They've all left the state. Every time you make a change, the reimbursement rates go down. I've talked to direct care service workers that were providing services in 2004 getting paid $20 an hour. The providers now are getting $20 an hour. So every time you make a change, the people that are doing the hard work are making less and less money. This plan that you create, it needs to be transparent. It doesn't need to be privatized. We don't need to be paying the CEOs $1 million every time. If you go privatize, that's what you're doing. You're lining the pockets of the CEO. You're taking money from the people that are providing the services, that are taking care of my son, not the CEOs who are sitting around buying their yachts. Okay, I went and looked at that 241-page plan. I did a search. I thought, I need to sort of brush on this. What are they going to do? The word disabilities was in that document 6 times. That document had approximately 150,000 words, and disabilities was written once. 4 times it was a definition, and 2 times it was in the comments. As a parent, that doesn't make me feel any good about any plan you have, how to protect my son and all the other families in this room. Thank you.
I'm a little nervous, so bear with me. My name is Robin Shepherd, and I'm a physical therapist, and I have a friend out there, Beth, so hopefully I can represent a category that hasn't been represented yet. I've been a therapist for 29 years, and 13 of the last years have been as a provider for the CDSA, which is the Children's Developmental Service Agency for birth to 3. So I'm often the very first therapist that a child ever sees, way before they see a mental health therapist. They may need that down the road. This has been my livelihood. I support my family, my 4 children, and my husband helps me with the billing. So what is decided upon in this meeting directly impacts my job, which I love. I love what I do. It suits my personality. I do not like working in a hospital, nursing home. I don't like to be in 4 walls. As soon as I can get a child walking, we're outside. We're natural. And I feel what I do has been very beneficial, and it gets the children ready for school. I'm also a school-based therapist. I recognize you. So I know what they need, and I'm very efficient in what I do. And if this, I know I'm jumping around with my thoughts, but there's a program going on in McDowell County called FIP. It's a pilot study that is going to directly impact what we do as individual physical, occupational, and speech therapists. They want to go to a primary provider model. That means they're going to decide, somebody's going to decide who's primary, PT, OT, speech, who knows. But yeah, you're going to be in charge, and you're also going to be in charge of what the other therapist should do. That needs to be left to the individual therapist to make up their mind if that child is medically needed to receive that service. And so I support maintaining at least the coverage that these children have. I know over the years I've actually got paid less when we bill, less for the evaluations. I do a lot of letters of medical necessity. Jane Lindsay, are you still here? Yes, ma'am. She knows me. I worked with this child that she referenced, didn't I? Yes. Helped her get equipment, provided the therapy. I spend hours. I get up at 4 o'clock in the morning to do my paperwork so I can do treatments all day long. This is just very personal to me. We've gone through audits where a lot of my peers have had to pay back $30,000 and $40,000. Fortunately, I went through it. If it had happened to me, I'd have been out of work. You know, I work for myself, just little private me. I'm a provider to Medicaid, Blue Cross Blue Shield, and it's just how I make my living. Want to go back to this FIP program. I think the pilot study is being skewed because of the fact that they've taken parent choice away from allowing the parent to choose the provider, and that should be a choice. Anyway, what I do 80% to 100% Medicaid, so this directly impacts what I do as a therapist, let alone the precious souls that I work with. Thank you.
Hi, my name is Lance Scholar. I work with Blue Ridge Community Health Services. Our CEO was here about 30 commenters ago, but I'm going to talk about a few different things. I'm in the forefront of helping people access health care, so our department helps people sign up for ACA or directs people to apply for Medicaid if it seems that they're eligible to do so, helps them with Medicare. So we're in the forefront of finding people who could potentially be in the Medicaid gap, and I kind of want to put a face on what it means to be in the Medicaid gap. For example, do you know how hard it is to qualify for Medicaid in North Carolina? For example, if you're a parent with 1 child, you need to make about $7,000 a year or less to qualify for Medicaid. $7,000 a year. So can you imagine how hard it is for me if I meet a parent who makes about $8,500 a year? This is a real case. You make $8,500 a year. I'm sorry, you're way too wealthy to qualify for Medicaid in North Carolina. You make way too much working at Burger King and make way too much working part-time to take care of your disabled son. So you can't qualify for Medicaid. You can't qualify for the ACA because you make a few $1,000s too little. Can you work a little more? No, you have to take care of your disabled son at home. I'm sorry. So this is the face of the Medicaid gap in North Carolina. The latest legislation in North Carolina to expand Medicaid, Carolina Cares, we're very happy to see that the legislature has proposed legislation to expand Medicaid.
The message that it does say is that people on Medicaid or people who want Medicaid don't necessarily want to work. And I would like to say that the people that I've met who would like to qualify for Medicaid really do want to work. One gentleman who I've tried to help get health insurance is a middle-aged gentleman, doesn't have children, so he can't qualify under the 44% FPL required to get Medicaid. But he's a landscaper and he has an issue with gout. And he wants to get medical treatment so that he can go out and landscape. But he can't afford the medical treatment, so he can't go out and landscape. And so if he could get Medicaid, get medical treatment, he could go back to work, perhaps make enough work to get off of Medicaid and maybe go on the ACA. But he can't do even any of that because we haven't expanded Medicaid. So by making people healthier, we can enable healthy people to work, and then they can be more productive members of society, and they can help many of our patients who really need access to health care.
Good afternoon. My name is Nancy Baker. I'm the parent of a 48-year-old, beautiful, wonderful, happy IDD son. And he is my angel. I'm also a parent who makes sure that he has the absolute best health care possible. I make sure of that. I make sure I find the doctors. I make sure I do the homework. I make sure I interview. If you don't go and can't match my interview questions that I want, you're gone. Because number one is, my son's all that matters. And you better be sure you know how to take care of him, because you're not going to lay hands on him if you can't. But most of all, stop all of these changes. I'm a parent who as is involved as any parent sitting here. I'm chair of the CFAC and I'm on VIA Health Board, and I can't keep up with all your changes. So how in heaven's name do you expect the common parent out here who isn't as involved as I am even know how to walk through this crazy world that you guys are giving us? I didn't ask you for it. You're giving it to me and telling me I have to accept it. So how in the world do you expect parents out in the rural communities to even know how to access care? I know it because I'm in it every day. I can walk in at VIA and I can ask questions and they better answer me. Not because I'm a board member, but because I'm a parent. I'm a parent that's going to demand to know what's out there. There's a lot of people who don't know how to do that, but I can tell you one thing, I do. And I'm going to do it. So don't push something down my throat that's not the best for my son. He's not a pawn. Nobody has the right to use my son's life as a pawn to balance your budget, to move money around. You nor nobody has the right to use my son or any other IDD, MI, or SA's life to get accomplished what you want in Raleigh. That's not fair. My son's life is the most important thing to me, and it will be until I'm 6 foot under, and then it goes to my daughter. And I can promise you one thing, she'll be standing right up here, and she's a whole lot meaner than I am. Thank you.
Number 49, for those of you who might be having a hard time seeing the numbers, as I was. Good afternoon, my name is Tammy Shook. I am the Social Work Division Director for Buncombe County Health and Human Services, and I'm here to speak specifically to increasing access to care and treating substance use disorder, as it specifically relates to the growing population of children in foster care in North Carolina. I want to point out that currently, when a parent loses custody of their children to social services, they also lose their access to Medicaid under current Medicaid rules, which state the parent caretaker must have a child under the age of 18 in the household for them to qualify for themselves. This significantly impacts parents' ability to access needed services to address the very issues that led to their children coming into custody of the Department of Social Services. Statistically, those issues are overwhelmingly mental health and substance use disorder issues. In Buncombe County, for fiscal year 16 through third quarter fiscal year 17, or 21 months, 190 children of 125 different mothers came into care due to substance abuse issues. If you look at just the first 3 quarters of fiscal year 17 alone, 71 children came into care, reflective of 49 different mothers. When you break that down even more specifically to women who are receiving MPW, or Medicaid for pregnant women, and are grappling with the disease of addiction, the pregnant woman, as you've heard previously talked about, is only eligible for Medicaid through the postpartum period, which is up to about 60 days postpartum. Recent data from Mission Hospital Systems reflects that approximately 400 infants were born with positive toxicology screens. Over 150 of those infants were Buncombe County residents. So when those women are even engaged in treatment prenatally, maybe on medication-assisted treatment and receiving treatment for their substance use disorders, they can lose their Medicaid 60 days postpartum and therefore lose access to their substance use disorder treatment. For those women who lose custody of their infants at birth, they are not eligible for any other Medicaid program due to the previously mentioned rule that they have to have a child in their household under the age of 18. Unless these gaps in coverage in the Medicaid system are adequately addressed, more and more children will continue to be separated from their parents, not just temporarily while their parents work to address the very issues that cause the children to come into care and have access to these services, but permanently, meaning permanently, because the system failed to provide them with access to the very services they needed at the very moment in time when they needed them to allow them to reunify with their children. Thank you.
Good afternoon. They run out of name tags and assignment to speak, but trust me, I'm under 50. My name is Frank Jervich. I'm a professional in Value Health, and more importantly, I'm a son of a parent with mental health needs. I simply want to advocate for a special needs plan for people who have severe and persistent mental health illness, addiction, children with severe emotional disturbance, those with intellectual or developmental disabilities, and others with long-term support needs. A special needs plan will offer the opportunity to improve care for those populations of Medicaid beneficiaries, primarily through improved coordination and continuity of care, and the ability to build a strong network. Thanks.
I'd like to thank the division for being here. I'd like to thank VIA for sending me an email. I'm also a CFAC chair for VIA. I serve on the state CFAC, but as a result of serving on the VIA CFAC, I also serve on the VIA Board of Directors. I'm probably going to speak for the folks that are not here. I did reach out to some folks yesterday trying to get some comments, so I'll read theirs first. Then when I get done with theirs, you'll know the rest are just mine, personal, more or less. I got a call yesterday. I'm interviewing for new CFAC members for our area, and I talked with someone, and her child has been on the waiting list for 9 years. And, you know, we both agree that's too long. She wanted to know why that there are just a few states that have waiting lists as long as North Carolina's, and she's from the Caldwell County area. Why North Carolina's waiting lists take longer to fill than other states, and where could she review the Medicaid waiver budget? And is there any research comparing the Medicaid waiver services by states to find the best approach to this problem? So that would be her comments, and I promised her I would bring them, so I've done that. Then the other, this is from all kind of people, and some of this came from the state CFAC chair, and they've got a really good, we talk about this a lot at the state CFAC, and we talk about the opioid epidemics and stuff. You know, want to thank everybody for their work on the opioid use and treatment and prevention issues. We want to especially say we need the STOP Act support. We appreciate the support for the STOP Act, but the STOP Act won't do a whole lot without the funding that's attached. So I want to advocate for the $20 million for funding for the STOP Act. You know, and prescriber limits on prescription opioids will drive more people to treatment. And that's a good thing. But the community treatment capacity is lacking. So, you know, we need to build that up. But anyway, that's probably enough about what they need. We just want you to fund recovery supports in that area. And I want to talk about mental health. I'm a little bit concerned. I kind of think over the past year or two, it's kind of been in many ways left out, even though there is the DOJ settlement and stuff going on. You know, I looked into the eyes of a friend of mine earlier this week that just got out of a mental institution when I was in the Raleigh area. Been in there for a month or two, maybe longer. You know, while she was there, and she's older than I am, and I'm in my 60s, she lost her home. She lost everything she had. You know, her personal belongings are somewhere in a storage building that she has no key to. And she does not live in the western part of the state, thank God, because I said that wouldn't happen where I live. That wouldn't happen in the Valley catchment area. You know, it may happen, but I hope it doesn't. But you know, I looked into her eyes, and she dressed pretty nice because she had on a new outfit because she didn't have any choice. Everything she has is somewhere else. But I looked at her, and she looked so fragile. Just the look on her face of what you look like when you come out and you've lost everything and you had to start all over again. You know, and I know this person pretty well, so I know when they know they're getting sick, they go and try to find help. But it's usually not to the point that it's available until it's way beyond going to an emergency room. She's probably going to an emergency room 4 or 5 times before she ends up being hospitalized, and then it takes months for her to get back on her feet, only to find she's even lost her housing and everything else she owned as a result. So we got to do better there. I want to say also that we must have a guarantee everywhere across this state of service available for all who need it, when they need it, when it comes to these mental health, substance use, and IDD. You know, and I think it can best be done by having some kind of guarantee that our LME, MCOs will live on in some kind of management capacity of these services in the future when all this is hammered out and we move forward to total person care. I do not think our consumers can or should have to handle another total shakeup of the system. I think it would be inhumane and increased lives would be at risk of loss. Complex care and specialty care needs for behavioral health and IDD need to continue to be managed by the MCO. Big outside companies don't have our experience in our communities and in North Carolina. Medicaid expansion needs to happen sooner rather than later. Care needs to be voluntarily accessible so that folks aren't involuntarily committed that went in the beginning asking for care. And I think when this happens, and they don't get the care when they go in and they're asking for it, when they lose everything they've got, like my friend has, I think that the people need to be accountable and they need to restore them when they get out of the hospital and they're penniless and homeless to the level they were before they went in. You know, and I don't think that means putting them in IMD or old folks' home. You know, I'm proud to be a CFAC member of both the state and local level, and I think CFACs need to remain and to be expanded. And if we do go to total care and stuff, they need to probably be expanded into the physical health side. And one place I really think they need them is DSS offices. They need to be at the table. People need to be at these tables, you know, and at every level. Seniors and folks on Medicare need more services and supports. There are far too many seniors taking their own lives, and others that are substance abusing, self-medicating. 7 to 10 years is way too long to wait for a slot. Peer support needs to be built into the new system at all levels, including the physical side. They need to be paid a decent living wage. Far too much attention has been paid to what those at the top earn in this system, and far too little paid at the bottom as far as earnings. Direct support workers and even consumers in supported employment must be paid more. Consumers need a place at all the tables where decisions are being made about them. Parents and family members also need to be present, but in no way should consumers be outnumbered or put down for speaking up, and they need to be treated with respect and not stigma. Again, fund the STOP Act. Mental health consumers don't have a unified voice. Okay.
I'll be short because I know we're running tight on time, but my name is Amanda Reed, and I'm the Director of Women's Empowerment at the YWCA of Asheville. I work with pregnant and parenting teens here in Buncombe County, and I've been working with teens here for about 1 year. In this short time, I have been able to see some of the issues that our pregnant and parenting teens face in and outside the home. Most of the teens I work with are of low income and also are minorities. Before I started this job, I'm embarrassed to say that I had never really heard of a coverage gap. But now, with working with these teens, I have seen it a lot. Sometimes people find out what I do and they ask, or they tell me, oh wow, baby's having babies. Isn't that so sad? Children shouldn't be having children. When a mother experiences a coverage gap, how is she supposed to get updated contraceptive use? So, I would like to call for an expansion to Medicaid and also universal access to insurance. Because if we're going to stop the cycle of our babies having babies, we need to make sure that they have access to care. Thank you.
54? Okay, yes. I'm 54. 54 or 54. Thank you.
I'm very surprised that I have an opportunity to speak. First of all, thank you for being here. Like some before me, I had prepared comments, but I've changed what I need to say. My name is Patty Wilson. I'm a behavioral health specialist. I'm with VIA Healthcare. I've been in the behavioral health field for over 30 years. And in that time here in North Carolina, I've seen a lot of change. Some wonderful, some not so wonderful. I too am advocating for bringing physical and behavioral health together to address the whole person. Most personally for me right now is the loss of my beloved nephew 2 weeks ago to an opiate overdose. A system that was more whole person oriented may have made a difference in that outcome for him. I hope it will make a difference for his family in the near future. I have been very moved by the voices of the people in this room today. People who are not advocating for an MCO system, people who are advocating for an MCO system. What is most clear is that people in this room have a passion for improving lives of North Carolinians, and I hope the words that we have all shared today are words that will be taken back to Raleigh and that we see improvements in all our lives and the people that we care about in the future. Thank you.
Oh, one more? Great, go ahead. I think you're our last speaker, so great, thank you.
I'm Pam Tidwell, and I am recently retired. I was a home health and hospice leader for 40 years, and so I'm coming from, not from an agency. And I want to advocate that we keep a model of case management in our Medicaid program. I've seen that work in our community. I think CCNC has done a remarkable job, and the thing that has been remarkable about that is that it's local. We do not need someone in Indiana or India or wherever it is working on case management. It needs to be local. They understand the community. And believe me, Medicaid is not the only source of services. There's faith-based communities. There's service communities that are doing a lot to support our people in their homes. So I would advocate that we keep a case management model, whether it's CCNC or something else, but keep it local. The other thing that I want to talk about, and people have addressed it today, is the expansion of Medicaid. And when I was in the field of healthcare, I was in the daily grind of how do you get services out? How do you get services out? And from this side of that world, it looks to me that our state has chosen a path of punishing our working poor. Our elected officials have sacrificed our working poor to undermine and destroy the ACA. This shames me. I am willing to pay more taxes to assure that all of our citizens get the needed care that they deserve. There's another way to address this besides expanding Medicare. There's a bill in the House and in the Senate that is expand Medicare for all. So look at that and see if that's something that you can get around so we don't continue this spinning and changing all the time. Thank you.
Okay, great. Thank you so much to all of you for being here today. I want to say a special thank you to all of our speakers, the healthcare providers, the family members, the individuals who need or receive services for sharing their stories. It takes a lot of courage. It's something that I carry with me and our team carries with them. So thank you to everybody for being here.